Welcome to our second week of Population and Family Health, Reproductive Health, MSPH student presentations. The ones last week were fantastic, and I'm really looking forward to this week's. So we're going to start with Isabella Sarria. She came to us from Johns Hopkins University with a BA in Public Health Studies. The title of her presentation is, Does Current Contraceptive Choice Affect What Other Methods Women Are Told About? A secondary analysis of counseling comprehensiveness in Ethiopia.
Okay, hi everyone. So as Mary Catherine said, my name is Isabella Sarria, and the title of my master's essay that I'm going to be presenting today is, Does Current Contraceptive Choice Affect What Other Methods Women Are Told About? And this was a secondary analysis of contraceptive counseling comprehensiveness in Ethiopia. So first, I'm just going to start with our findings just to provide some context and to show where we're headed in this presentation. So our findings from this analysis was that over 50% of all current contraceptive users, regardless of type, reported being told about no other methods in their current one. This was found to be highest among implant and pill users. And among women who were told about other methods, specifically one other method, the highest frequency was among injectable users. We also found that the type of current contraceptive method, so short versus long acting, so the pill versus the IUD, for example, the source of the method, whether it was a public or private facility, wealth, education, and parity, also played a role and affected the likelihood of being told about other methods. So more specifically, we found that wealthy, educated, multiparous, so the women who've had children previously, users of short-acting methods were more likely to be told about other methods in their current one. And we found that women who retrieved their contraceptive choice from private facilities were significantly less likely to hear about any other methods. So just to provide a little bit of background, again, a little bit more context, we know, and it's a fact, that the provision of unbiased, non-directive, comprehensive contraceptive information supports the rights of women to make informed decisions about their sexual reproductive health. We also know that when women receive comprehensive care, they're more likely to continue using contraception or uptake contraception, and they're also less likely to discontinue their contraception. However, even knowing that, there are still a lot of statistics within Ethiopia that show that contraceptive counseling has room for improvement. Only 13% of women have reported receiving high quality family planning, and over 50% of women in previous studies reported not being told about any other contraceptive methods. And comprehensive contraceptive counseling is still below 40%. All of these are measured by very notable measurement tools. One of note is the Measurement Information Index, which is a globally used index that measures contraceptive counseling quality around the world and in varying countries, including Ethiopia. And previous studies have also shown that the type of current contraceptive, again, short acting versus long acting, the implant versus the injectable, do play a role in the received care of women. And finally, some qualitative studies have uplifted and highlighted biases within contraceptive counseling, have lifted women's experiences where they have said that they have felt that they've been directed towards certain type of methods or not really given the range of options that they should have. So finally, the research gaps that we're going to fulfill within this study, we want to continue to understand the association, again, of the current contraceptive choice that a woman is using and the specific type and number of other methods, contraceptive methods, that women are being told about. So when a woman walks into a provider's office looking for a method of contraceptive, what are the range of methods she's going to be told, if any at all? And we want to understand the impact of individual characteristics, of sociodemographic characteristics on the number of other contraceptive methods that women were told about. So just a bit about our methods. So the study itself had around 8,837 women that were interviewed. Our specific analytic sample was restricted to 2,071 women who were current users of hormonal contraceptives, including the implant, the injectable, the pill, and an emergency contraception, or the non-hormonal IUD. And when they were interviewed, they were asked, were you told about other methods? If they responded yes, they were asked a follow-up question that asked them, what methods were you told about? And these women selected all the methods that they were told about, that they heard. And we used those two questions to create our overall measurement outcome, which was the number of other methods women were told about, 0, 1, 2, and 3+. And so just a little bit about our analysis. We began with a descriptive analysis of other methods. So what other methods were we told about? What were the frequencies ranging from female sterilization to the pill to the IUD? What number of other methods were women told about, if any at all? And this was observed among all users and also among specifically the implant IUD and the other method types that we included in our analysis. And from there, we moved on and did an unadjusted and adjusted multinomial regression to further explore these relationships. And the adjustment variables that we included, it were method types. So as I mentioned, short-acting versus long-acting, the source, public versus private, the region, the varying regions of Ethiopia, wealth, education, and parity. And we also accounted for complex survey designs at all stages of our analysis. And so finally, our results one more time. Over 50% of all users, regardless of method type, all the ones that I mentioned previously, reported receiving information about no other methods. If they were told about other methods, they were most likely to be told about the implant or the injectable. And users of short-acting methods were more likely than their long-acting user counterparts to hear about one or two other methods. And varying sociodemographic characteristics were related, and I'm going to highlight a couple of those in the coming slides. So as you can see here in the red box above, users of short-acting methods were nearly 3 times as likely as their long-acting user contraceptive counterparts to be told about one other method, also nearly 2 times as likely to be told about 2 other methods. The source of the method, so as I mentioned, private facilities, they were significantly less likely to be told about 1, 2, or 3+ other methods when compared to government hospital or health centers. And women of the highest wealth quintile, along with women of the highest education status, were significantly more likely to be told about 2 or 3+ other methods. And so what does this mean? What did we find? So we do know that there are gaps in contraceptive counseling, and this continues to uplift that. We can't make conclusions about intentions or the reasons why these gaps exist. It may range from, short-acting users being directed towards long-acting, just the receipt of care, the source. We can't make conclusions about that, but we know that the gaps do exist. We know that these differences exist among different method types between short-acting and long-acting, and that various sociodemographic characteristics are also related with the uptake of and receival of care. So women who are using these private facilities, again, significantly less likely to be counseled on other methods than the one they have, and highly educated and wealthy women are more likely to hear about other methods. And so what does this mean? So again, we want to uplift women's experiences. We want to make sure that contraceptive counseling is actually comprehensive, especially given the LARC first approach that is happening around the world, wanting to push contraceptive methods that are going to help uplift and support women's reproductive desires, whether they want or do not want children, at what time. We want to continue to support that. And so person-centeredness is really the highlight of this and the desire that we want in uplifting these findings, and making sure that we can create standardized counseling so women are walking into an office and being told all their options so they can make the choice that best serves them and their reproductive desires. And finally, we want to continue to improve the private sector. We want to engage providers. We want to improve training, and we want to continue to improve access to contraceptive methods so these facilities feel prepared and they have the resources to provide the best care possible to the women who are coming to see them. And so women are receiving, again, the best care possible for them and their needs. And as I mentioned before, the overall goal of the study and just of the work that we do in general is to always uplift the reproductive rights of women and to support their needs and their desires. And so just a couple of acknowledgements. I just want to acknowledge my thesis advisor, Dr. Linnea Zimmerman. She's been an amazing mentor in finding my love for women's health and learning data, doing all this fun stuff. The PMA Ethiopia team for allowing me to work with this data set and to continue to learn from all your papers and all the work that you all are doing to uplift reproductive health in Ethiopia. And just my family, friends, peers, and mentors. I really appreciate you all. Really happy to have been able to go through this program for amazing people and the support of my friends and family who are here today. Thank you so much.
I just wanted to ask, I did a very similar talk at like looking at contraceptive preferences and how we measure like women's preferences. And I was wondering, when you're looking at these women and their methods, were there any talks or anything about kind of looking at maybe the current method they're using is not the one that they feel most satisfied with? And of course, if you didn't see anything like that, do you think there is room for that type of study to be done in Ethiopia?
Yeah, that's a great question. So I specifically didn't look at whether or not people, like women that were using their current contraceptive, felt completely satisfied. That was a bit outside the scope of this analysis, but I definitely think there's always room to include that into, just because women are on contraceptives, that does not mean that they're necessarily satisfied with the contraception they're using. And so that is definitely another question that we need to continue to uplift. And it's a great question. Yeah, thank you.
Hi, Bella. Really great presentation. I was just wondering, like, what interested you about this topic? Like, why did you choose to do your thesis on this?
Yeah, thank you so much. So, I think that um, what interested me in it was I think that at least for me, at least like, when I was young, or at least like just coming into women's health, I think I had this perception of like, oh, if a woman's on contraception, like, okay, she doesn't want kids, like simple as that. And, her desires are met. But I think as we all know, that's not true. A woman's experience in contraceptive care and reproductive health as a whole is very complex. And so I think understanding the experiences that women are having in the office, in a provider's office, instead of just the result of what happens in that office, is extremely important, so that we can hold accountability for providers, help providers know what they can do better and how they can better serve women, and at the same time just better understand women and their desires as well. And so I think this really combined my interest of clinical work and also of women's health, and kind of bringing them together to see like how can we make it better on both sides.
Nice job, Isabella. Congrats. I had a clarifying question before my question, which is the stat on the 3 times more likely to have received info among the women who were on short acting contraceptives. Was that compared to women on no or women on long acting? Oh, okay. So yeah, that kind of feeds into my thought, which is like, I feel like maybe the goal of a lot of these like foreign assistance on family planning, like agencies in particular, are to try to get women on more long acting contraceptives. And I guess I'm wondering what your like thoughts are on, does that 3 times more likely among those women who are on short acting contraceptives, like, is that actually an indicator that certain foreign assistance family planning programs like are working because we're trying to counsel those women for longer acting contraceptives?
Yeah, I think it could definitely indicate that. I think it could mean a lot of different things, but I think I think that even if we're trying to introduce, long acting contraceptives, I think just like making sure that women are being told about a range regardless, because, even though like LARCs are, a good method of contraceptive that, help meet some people's reproductive needs, for some women, long acting contraceptives aren't what they desire. And so I think like, even if someone is on a short acting contraceptive method, I don't necessarily think that that means that they need to be pushed towards long acting, because I think what that specific woman wants is what takes priority. And so, it is a good thing that, they are being told about other methods, but I think learning more about what they're being told about and in what context, like if we're being pushed towards one versus the other, I think that's kind of where the problem exists. But again, this is just like me contextualizing it. This is not, what made it happening necessarily, but I think just seeing that those like that they're more likely to be told about something, whereas like long acting, why aren't they also being counseled on other methods? Like what if they desire different methods? And so I think just those differences, I think is the main highlight of this for me at least.
Okay, so our next presenter is Ahylexus Kidd. Alexis came to us from Towson University with a BA in biology. The title of her presentation is Addressing the Role Slavery and Racial Stereotypes Play in the Low Occurrence of Initiation and Continuation of Breastfeeding Among Black Mothers.
Good afternoon, everyone. My name is Ahylexus Kidd, and I will be doing a presentation on addressing the role that slavery and racial stereotypes play in the low occurrence of initiation and continuation of breastfeeding among Black mothers. Just a general overview of what will be discussed today. I will be going over the introduction, methods, results, and discussion. So first, I want to give a background on Black women, how the past is affecting the present. The origins of racial disparities in breastfeeding rates began during slavery, and the disparities between Black and white women are still being presented today. The decision for African American women to breastfeed is tied to generational trauma of wet nursing during slavery. A wet nurse is defined as a woman who is employed to breastfeed another woman's child, but during slavery, Black women were not employed, they were forced. This destroyed the intimacy of breastfeeding in the African American community. After slavery, Black women were still being dehumanized and referred to as a mammy, which is a racial stereotype representing a Black woman who works for a white family and cares for white children, but not her own. So this led to a stereotype that Black mothers are unfit, and if they are unfit, they couldn't possibly have time to breastfeed their own children. This led to the push of formula companies encouraging Black mothers to buy and use formula instead, ultimately taking away from the decision to breastfeed. The decision to breastfeed in the past has highly influenced the decision to breastfeed in the present. So what is breastfeeding and why should you care about it? Well, breastfeeding is the healthiest and most effective way of infant feeding, especially in the first 6 months of life. It is beneficial for both mother and infant, but especially in the Black population. The Black infant mortality rate is twice as high as any other racial group, and breastfeeding has been known to be associated with infant survival. Black breastfeeding rates in the United States are extremely low, and increasing breastfeeding rates can lead to an overall increase in the health and well-being of the Black population. Although breastfeeding rates in the United States has increased, the breastfeeding rates in the African American community are still lagging behind. So this figure here shows breastfeeding initiation rates from 2010 to 2018 among the racial groups. As you can see, Black women are the yellow line that's at the bottom, and compared to other racial groups, Black mothers initiate and continue breastfeeding at a much slower rate. The Healthy People 2020 Breastfeeding Initiative target goal was 81.9%, but it's reported that only 74% of Black women initiated breastfeeding. So in this figure, we're looking at the disparities of breastfeeding rates among the racial groups in 2019, and we're comparing if they ever breastfed into 6 months, and breastfed into 12 months. Black women have the lowest rates for each category. With this said, the objective of my review was to examine how wet nursing during slavery has affected the way Black women view breastfeeding and how racial stereotypes throughout the years have played a part in medical professionals providing less lactation to support to Black mothers, causing a low occurrence of initiation and continuation of breastfeeding. So for my methods, a search strategy was created to find literature on PubMed, Web of Science, CINAHL Plus, and sociological abstracts databases. A keyword search strategy was utilized. The search terms included African American mothers, Black mothers, breastfeeding, bias, discrimination, formula, infant nutrition, racial stereotypes, and wet nursing. And I do just want to make a note that in this presentation, African American and Black will be used interchangeably to describe the same community. So for screening, the literature searches yielded a total of 703 articles, and after scrolling through each database, 372 duplicates were removed, leaving a total of 331 articles to screen. 292 articles were excluded because they did not meet the inclusion criteria. The remaining 39 full-text articles were assessed for eligibility. Based on the inclusion criteria, 32 articles were excluded, and a total of 7 peer-reviewed journal articles were included in this review. So this table includes a summary of each selected study. Of the 7 studies selected, 1 explored the history of breastfeeding in African American mothers, 4 assessed the perception of breastfeeding among Black mothers, 1 explored the relationship between healthcare professionals and the Black community, and 1 examined the racial differences in receiving lactation support between African American and white mothers. The first study was a qualitative study done by Devon Johnson and colleagues. They focused on why Black mothers weren't breastfeeding. They identified 6 themes. 3 of the themes have already been explored, which is it takes a village, real world issues, and personal realities. And the other 3 themes are underexplored or non-existent, and they include historical trauma, negative body image, and breastfeeding is nasty. The next 4 studies were qualitative studies done by Obag and colleagues, Gross and colleagues, Lawan and Street, and Hines and colleagues. They identified similar themes in their findings on what influences the perception of breastfeeding among Black mothers. The common 4 themes included lack of information about breastfeeding, family and community support, negative perception of breastfeeding from others, and historical factors and culture beliefs about breastfeeding. The next one was also a qualitative study, and it looked at the relationship between African American mothers and healthcare professionals. And this was a study done by Johnson and colleagues. The 4 themes that resulted from this study included breastfeeding support from healthcare professionals, the difference in types of breastfeeding support, healthcare providers and trust, and culturally relevant support at the multiple levels. And lastly, there was only one quantitative study, and this was done by Bill and colleagues. They analyzed data to examine the racial difference between African American and white mothers, and they found that African American women were less likely to receive breastfeeding advice when compared to white women. So overall, the main key finding from this review indicated that factors such as race, culture, history, and tradition influence the decision to breastfeed among Black women, as well as interpersonal relationships, community, and interactions within the healthcare system. Although Black mothers agree that breastfeeding is the healthiest method of infant feeding, the racial disparities presented in the healthcare system and community have an impact on their decision to breastfeed. In addition to this, breastfeeding is viewed in a negative way in the African American community, especially among the older generation, due to these generational gaps of breastfeeding in the population. So with this said, I recommended 3 possible interventions that could happen. Training healthcare professionals on historical and cultural factors that impact Black women, diverse lactation and breastfeeding community members that Black mothers can trust and educate them. And lastly, community-based educational groups that educate African American families on the importance and benefits of breastfeeding. A major strength to the studies were their study designs. However, a limitation was that the literature was either outdated or limited. To conclude, further research still needs to be done on this topic. There's evidence provided to show there is a relationship between low breastfeeding rates and historical cultural factors, and interventions need to be put in place that target Black mothers directly and consider these factors to help increase the occurrence of initiation and continuation of breastfeeding. And before I end, I just want to give a huge thank you to Susan. She was my primary reader, and literally none of this could have happened without her. So thank you so much, Susan. I also want to say thank you to Mary Catherine, because almost every week she was emailing me, making sure that I was okay. Hi, Mary Catherine. And then Kristen, because Kristen was always one email away. With any question that I had, she always got back to me. I want to say thank you to my Core Hope Pop fam. I love you guys so much. And then last but certainly not least, I want to say thank you to my mommy. I won't get too much into it because if I thank her too long, I might start crying. So thank you, Mommy. I love you so much.
Yay.
That's it.
Nice. Okay, I'm trying to see if there's any questions in the chat. Oh, I see. No, I saw some hands up, but maybe not.
I see one question in the chat from Maanasa.
Yes. Are there any initiatives and or interventions that are currently in place now that you think is helping with the increase of breastfeeding rates among Black mothers?
Yes. So since I had limited time, I couldn't really get into the interventions that are currently in place, but there's 2 that I did discuss in my thesis. One is the WIC program. If you're not familiar with the WIC program, it provides information on breastfeeding to low-income mothers. Also, the Baby Friendly Hospital Initiative. It promotes and supports breastfeeding in the hospital by outlining 10 successful steps on how to breastfeed.
just want to say thank you for this presentation and this topic. It is super, super important. I did have a question maybe too about the literature that you reviewed. Were you finding that these were mostly looking at like women who breastfed versus not? Was there any like semblance of like, are there women out there who may be breastfeeding and bottle feeding, like a combination?
Yes, so the literature that I looked at, for the 6 qualitative studies, they did focus groups. And so within the focus groups were either women who breastfed, women who did not breastfeed at all, or women who breastfed only to 6 months. And so within those focus groups, they took the answers from all 3 women, and that's how they came up with the themes of what is either stopping women from breastfeeding, what is making them breastfeed, or what is their reason that they don't want to breastfeed at all.
Awesome, thank you. And then just a follow-up to Manasa's question. You had mentioned these 2 programs, particularly WIC, and something that just came up for me as I was thinking about why breastfeeding might be lower among this population that's also connected to structural racism is the types of employment that people might have and the opportunity to do things like pump while working. I'm just wondering your thoughts on things like that.
Yes, so actually it was so much that I had to cut out because of time, but it was also in my thesis that it is a disadvantage to some mothers, especially Black mothers who are low income and they have to work. A lot of mothers have the opportunity to be off of work after they give birth, but a lot of them go back to work right after. So in that case, I believe it was the first study that looked at Devon Johnson and colleagues. One of the reasons that mothers did decide not to breastfeed was because that unfortunately they had no other support that would have the baby, that they could stay home and have someone go into have their income. So they would have to go into work. And that's the reason that they couldn't breastfeed. They had to do formula.
So our next presenter is Maanasa Chitti. Maanasa came to us from Vellore Institute of Technology with a Bachelor of Technology in Biomedical Engineering. The title of Manasa's presentation is Bumps in the Road, Assessing Facility Preparedness to Address Intimate Partner Violence During Pregnancy in Ethiopia. So Maanasa.
Good afternoon. My name is Maanasa, and the title of my essay is Bumps in the Road, Assessing Facility Preparedness to Address Intimate Partner Violence During Pregnancy in Ethiopia. So let me start out by defining intimate partner violence, or IPV. IPV refers to any form of physical, sexual, or psychological abuse that occurs in a current or past romantic relationship. For the purpose of this study, I'll only be discussing physical and sexual IPV. IPV is the most common form of violence against women, with nearly a third of ever partnered women having experienced IPV at some point in their life globally. So because pregnancy is such a complex time period, IPV during pregnancy is particularly unfavorable because of the many direct potential consequences on both the mother and the fetus's health. A recent study has shown that before the pandemic, 10.5% of women in Ethiopia experienced IPV during pregnancy, and during the pandemic, it increased to 15.1%. This prevalence estimate is significantly lower than the global estimated average of 25% and Africa's estimated average of 36%. It's very likely that these figures are underreported. Ethiopia is a patriarchal society where the idea of violence against women is very normalized. And to put that into context, around 70% of women and 50% of men in 2016 thought that wife beating was justified. And there are legal provisions in place to protect women's rights, but people and authorities are largely unaware of these policies, and so they're poorly enforced. This leads to underreporting and low levels of prosecution. Other barriers to help seeking include perceptions that the violence is not severe enough, a fear of consequences for the family, and a general distrust in institutions that do address IPV. Barriers can also be attributed to social norms that shame women into silence and healthcare inaccessibility across Ethiopia. There's limited research that exists on IPV against pregnant women in Ethiopia and the association with the availability of IPV support services, but studies have shown that high cost of travel to and the fear or the shame of going to healthcare institutions are significant barriers to formal help seeking, which causes delays in timely care and decreased maternal service utilization, unfavorable maternal and child health outcomes overall. So for women in lower and middle income countries like Ethiopia, where a majority of the population lives in rural areas with limited infrastructure, healthcare services are inaccessible. Adequate support to victims of IPV during pregnancy and the postpartum periods is critical, not only due to the implications on both maternal and fetal health, but also because an abusive partner could continue to be violent after the pregnancy and could interfere and restrict access to healthcare and pose threats to the child's safety. In this regard, our study aims to identify areas with high prevalence rates of IPV during pregnancy or hotspots and examine their existing facility adequacy based on IPV service provision. So by understanding the factors that affect facility adequacy, we can begin to ensure whether these regions have the necessary support in place for women. This specific study analyzed 2 data sources from PMA Ethiopia, or Performance Monitoring for Action Ethiopia, an initiative that provides information on key reproductive, maternal, and newborn health indicators. In this study, I used the Service Delivery Point, or SDP survey, and the panel study. The SDP survey provides information on the availability of services at public and private healthcare facilities across all 11 regions of Ethiopia. The panel survey included women who were pregnant or less than 6 weeks postpartum when they first enrolled. So this included women from 6 regions of Ethiopia that are marked in purple on the right, and they represented 90% of the total population. Our study specifically focused on partnered women and used 6-week postpartum follow-up data for the most accurate recall of violence during pregnancy. There's more details about the sample and the sampling strategies in the protocol by Zimmerman et al. The primary outcome of interest was IPV, and we used the panel study to determine IPV hotspots. Violence was categorized into 3 dichotomous measures: any physical IPV, any sexual IPV, and any IPV. 10 binary items from the revised conflict and tactic scale were used to measure violent behaviors at any time during pregnancy, and an affirmative response to any violent behaviors was categorized as any IPV experience. Physical IPV included the 7 items on the left, and sexual IPV included the 3 on the right. Now onto the SDP survey, which is what we use to assess facility adequacy. There were 6 different facility types that we used in the sample. We evaluated adequacy through 2 multi-response questions from the survey. In the first question, respondents were asked if the facility provided psychosocial services for the types of violence listed on the slide, and if they responded yes to at least one of these, and they were directed to the next question. The next question assessed if the facility's psychosocial package included any of the services listed on the far right of the slide. I performed descriptive analyses for the results from both data sets. Responses to the 2 SDP questions were tabulated to compare the availability of facilities and services across facility types, regions, and managing authorities. I performed descriptive analyses on the panel study sample as well as a subgroup of women who did experience IPV, but for the purpose of this presentation, I'll be focusing on the SDP results. Of the total study sample, 182 women experienced any IPV during pregnancy. Sexual IPV was more common than physical, which you can see here on this slide. The 3 bars on the right in the purple represent responses to the sexual IPV items, which were visibly more common than physical IPV. Here, I broke down service availability by region, and looking at some trends, if we start from the top, we can see Amara had the greatest percentage of IPV experiences during pregnancy, and going down, we can see that Addis Ababa had the least. We can also see that across all regions, medical care was the most offered service in psychosocial care packages. Housing, legal aid, and post-exposure prophylaxis for HIV exposure were not as commonly offered. Amara is also the only region with a relatively high percentage of facilities offering psychosocial services to IPV victims. When we look at facility type, we can see that it was mostly hospitals that provided a psychosocial package, but in the interest of time, I'll reserve a more detailed discussion of these results for the Q&A. Here's a facility type breakdown of services included in the psychosocial care package. So across the board, we saw that medical care was prioritized across regions, but medical care alone may not address the root causes of IPV during pregnancy or provide the victims the necessary long-term support that they need. This suggests that there's a focus on immediate medical care and that there may be a lack of recognition of the holistic impact of IPV. It's likely that the availability of comprehensive IPV services is affected by the absence of a formal national budget for IPV. This leads to overburdened and underpaid healthcare and legal workers and difficulty retaining trained personnel. Social and environmental factors can also restrict access to care. For instance, there's been recent political violence in Oromia and a recent humanitarian crisis in Amara that has caused road closures and disrupted healthcare infrastructure overall. Conflicts can also exacerbate pre-existing risk factors for IPV, which makes it even more challenging for survivors to access these healthcare services. In SNNP, there's over 7 languages spoken, so if someone doesn't speak the same language as their provider, this could lead to mistrust, inadequate care, and could discourage patients from returning altogether. So one of the main implications of limited healthcare facility and availability is that it perpetuates the stigma associated with being a victim and reinforces gender inequity because it promotes a climate that shames women for speaking up rather than shaming their abusers for abusing. There's also strong social norms and structural barriers that hinder survivors from accessing support, services, and justice, which contributes to underreporting and underestimation of IPV prevalence. The main limitation of this study was that we weren't able to directly link individual women's responses to their nearest available facility. In this regard, this is probably one of the next steps. So by linking these 2 data sets, we can have a more thorough understanding of who is experiencing IPV, where they seek care, details about the facility and the services offered, which can hopefully inform interventions to target the most affected areas. I can elaborate more on Ethiopia's healthcare system during the discussion. So improving access to IPV requires a multifaceted and intersectional approach, which could potentially include formal budget allocation to ensure the adequate resources, not just for victims themselves, but for health and legal staff to be adequately equipped to address IPV. Raising awareness, integrating services into ANC, and community-based models are also essential. These approaches together can begin to address the complex nature of IPV. It's clear that IPV during pregnancy in Ethiopia poses health risks to mothers and infants. Barriers to accessing necessary services, such as strong stigma and social norms, are exacerbated by factors like limited resources, conflict, and natural disasters. A comprehensive strategy to address these obstacles is crucial for optimal maternal and child health, gender equality, and women's empowerment. And it's only through a concerted effort to break down these barriers that we can hope to create a safer, healthier, and more equitable future for women and their children. Firstly, I would like to thank Dr. Shannon Wood, my first reader and my field placement advisor, for her guidance, support, and patience over the last year. You've really made this work as simple and as straightforward as it could be. Secondly, I'm grateful to everyone in PopFam, my mentors, or really anyone I've had the pleasure of meeting here in Baltimore over the last 2 years in grad school, both inside and outside of Hopkins. I learned something new from you every day, and you are what makes Baltimore feel like home. And to all my family and friends and all the cats and dogs who are here on this Zoom call, literally either sitting in the room next to me or from all over the world, I appreciate your support and encouragement so much, and I'm so grateful for your presence in my life. Thank you.
Nice job.
Hi, great presentation, Maanasa. I really enjoyed it. Also, your title was very clever. I appreciated that. So I noticed that Addis Ababa had the lowest IPV, but also only like 20% of the facilities that catered to victims. Can you talk a little bit more about that?
Yeah, sure. Thank you. That's interesting. And can you see the slide? So I think you can see the slide that I'm showing, but This
Yeah.
actually ties in with the tiered healthcare system in Ethiopia. And as you can see in the diagram, there's primary healthcare looks very different in urban and rural settings, but as you move up the tiers, the facilities become more specialized and can serve more people. Addis Ababa, being a metropolitan city, has a lot of tertiary facilities that can serve millions of people. So there may not be many facilities catering specifically to IPV victims, but it's possible that the ones that do are the big tertiary facilities with the capacity to support a large population. And kind of on the other side of that spectrum, we saw that in Amara, 80% of facilities provided a psychosocial package. Maybe a majority of these are smaller primary healthcare facilities that might not necessarily reach the same amount of people that 20 to 30% of facilities in Addis do, which, like, of course, in a rural area, that's a significant barrier because it's mostly big hospitals providing IPV services that rural residents have to travel long distance to. And that's why our study was limited, because facility numbers alone don't necessarily paint the full picture of a region's capacity to adequately address issues like IPV. So it's also important to consider factors like facility type, geographical distribution, and accessibility to the population in need, which is definitely the next step.
Hi, yes. Thank you for the presentation, Maanasa. It was very informative. So I was wondering, what does help seeking look like in Ethiopia right now if it's not formal? Or are there ways to like replicate informal help seeking in this formal setting?
Yeah, thank you for the question. So in Ethiopia, I think community and respect for elders are like core cultural values. So a lot of the informal help seeking involves conflict resolution between the victim and the perpetrator's family. And that conflict resolution is mediated by someone older. And, given that they value community-based interventions are really important and likely to work since they're culturally sensitive, which this is somewhat unrelated, but I also think it's why it's important for there to be more services available at health posts, because it's typically just, one or two people working at a health post and they know the community like the back of their hand. So that trust is already established and it's a safe space. So people are more inclined, like patients are more inclined to be open and share with their healthcare workers. And also a lot of the time, a health post is just what is the most accessible. But I remember reading about one particular intervention. I forget what it's called. I think it might be Unite for a Better Life. And it's what's called a gender transformative approach. It's a community-based program that involves men, women, and couples in discussions aimed at transforming gender roles and addressing power imbalances, and it focuses on skill building for healthy, nonviolent, equitable relationships. And I think this program is specifically targeted towards young couples, which is nice because young age, I believe, is a risk factor for IPV during pregnancy. And that program is delivered through a traditional coffee ceremony, which is a forum for community gatherings. So because it's relatable and incorporates their culture within that community setting, I think people are probably more inclined to participate.
Okay, so our fourth presenter is Samantha Alarcon Basurto. She came to us from Portland State University with a BA in Public Health Studies and International Studies. Title of her presentation is Identifying Community Strategies to Promote Breastfeeding Practices Among American Indian and Alaska Natives, a systematic review of US and Canadian studies. Samantha?
So thank you for the wonderful introduction. I am Samantha Alarcon Basurto, and I'm going to be sharing with you community-specific strategies to promote breastfeeding practice among American Indian and Alaska Natives. So first, profound gratitude to my advisor and reader, Mary Catherine Augustine. The multiple revisions and critical feedback throughout the writing process totally challenged me. However, I'm very proud of the end result with this project. Second, boundless appreciation to my family, friends, and colleagues whose unquestionable support and cheerleading got me through the finish line. So I will start by defining our study population, followed by the research question to be answered. I will continue sharing relevant details of the methodology with an emphasis on eligibility criteria and study limitations. An adaptation of the standardized Prisma flow diagram will also be shared, where its implementation can help ensure the level of uniformity of the review. Not all the strategies are going to be presented on the results section of this presentation, but key messages for each of the community-specific themes will be identified and later discussed. So for the purpose of this study, American Indian Alaska Natives in the US territory will, refers to both individuals who are identified as only or in combination with another race. As for Aboriginal peoples in Canadian territory, it refers to First Nations, Métis, and Inuit, alone or in combination with another race. So the persistent disparities in breastfeeding initiation and continuation of this study population inform a research question. How can the inclusion of community-specific strategies influence the promotion of breastfeeding behavior and practice among American Indian and Alaska Native populations and Aboriginal peoples? So despite the limited number of peer-reviewed studies that solely focus on our study population, literature on infant feeding behavior have shown potential breastfeeding interventions. For instance, a study on the American Indian community in Minnesota found links between the use of traditional native medicines and higher rates of breastfeeding at 6 months, which suggests that the promotion of traditional indigenous health practices could help promote interest in breastfeeding practice. The objective of this systematic review was to identify and list American Indian and Alaska Native population specific community strategies to address breastfeeding behavior and practice. I'm going to share now the inclusion and exclusion criteria which dictated how to filter through these studies. The inclusion criteria encompasses peer-reviewed studies, including promotion of breastfeeding behavior and practice as one of the study objectives. It could be either primary or secondary. Also, the study only measures American Indian and Alaska Native populations. And this is mostly sort of attributed to maximize the relevancy of our study results. And further, the studies are restricted to only US and Canadian territories. And this is mostly because of the capabilities of our search terms. And as for the exclusion criteria, primarily highlight that we're not including reviews, position pieces, analyses, or evaluation studies, and studies not written in the English language. I believe it is important to provide a rationale of why the inclusion of Canadian studies, primarily the term Alaska Native, can be used interchangeably for Inuit. Also, only 4 studies were found in the US territory, and to increase the sample size, the inclusion of Canadian studies definitely let us do that. To highlight some of the limitations in the generalizability of our study results, they're specific to the communities interviewed. The study sample sizes of each critically analyzed study was very small, and the present literature review did not include a quality assessment of each of the critically analyzed studies, so just to have that in mind. Now I'm going to walk you through every step of the Prisma flow diagram. The systematic literature review utilized 5 databases, and the number displayed next to them is the number of studies identified in each database prior to get the duplicates out. The review does not include any grade literature, or it does not incorporate any reference list searching. So search terms were then created around 3 main concepts: breastfeeding, our study population, health promotion and education. After removing the duplicates, we see that we remained with like 22 studies who were then abstract screened to see if they included breastfeeding as a study objective, and 11 studies were excluded. After a full text review of 11 remaining studies, 3 studies were excluded since they failed only to focus on our study population, and therefore 80 studies remain for critical analysis. The purpose of this systematic review was to identify and list American Indian, Alaska Native population, and Aboriginal peoples community-specific strategies. So under the sub-theme, strategies for development of research protocol materials and deliverables, failure to use materials that are culturally appropriate or relevant can be ineffective or even harmful, as they might not resonate with the intended audience or might even contradict their cultural norms and beliefs. Under the sub-theme, strategies for social support, Social support can take many forms, but what is important to highlight here is the diverse sociocultural relationships of women with their mothers, aunties, sisters, spouses, and community members, since research has shown that traditionally women would often consult their family members before consulting healthcare providers. Under the sub-theme strategies for external stressors, many of our study population currently impacted by substance abuse and had to give up on breastfeeding and choose bottle feeding instead to protect the health of their infants. However, healthcare providers need to offer non-judgmental support and resources to mothers struggling with substance abuse to help them make informed decisions. Under the sub-theme, strategies for environmental stressors, evacuation policies for Aboriginal peoples particularly have had a significant impact on breastfeeding behavior and practice. Individuals were forced to leave their communities and social support networks, therefore disrupting breastfeeding practice. So policymakers need to consider the cultural and social context of the communities they serve and further work with local leaders and organizations to ensure that the mothers and infants have the support they need to continue breastfeeding. Lastly but not least, under the sub-theme of strategies for addressing misconceptions and inconveniences, although American Indian, Alaska Native populations and Aboriginal peoples know of breastfeeding importance, misconception about the practicality of breastfeeding, such as fears of low milk supply or issues with latching, can totally deter mothers from continue breastfeeding or ending breastfeeding sooner. Therefore, there is a need to enhance educational breastfeeding programs for this particular community. So based on the previous analysis, my recommendation is that even though our study population faces a range of challenges to breastfeeding, there is a potential for the incorporation of community-specific strategies to promote and support breastfeeding practice behavior. What is important here is that when the community is involved at every step of the research and implementation process, and the health intervention is tailored to them, then the mother's experience and attitudes towards breastfeeding practice are addressed. Thank you so much to the audience for their undivided attention. Any questions? To answer Andrea's question, what motivated me to pursue this research? I had the tremendous pleasure to have been given an opportunity to support the Native Communities Research team at Hopkins under the direction of Dr. Gittleson. And I onboarded as a research assistant to help with coding and analysis of the research study on WIC participation, specifically to two native communities, Navajo and Keweenaw. I quickly learned that community-based approaches and participatory research methodologies were the best tools when conducting research in these communities. I wanted to then focus on a topic that is very close to my heart, breastfeeding, and it's then that I decided to look at past strategies that have existed or have worked previously, and any recommendations suggested by authors working with this particular communities.
So our last presentation is Shiyu Liu. Shiyu Liu came to us from Southern Methodist University with a BS in Biological Sciences. Title of Shiyu Liu's presentation is Scoping Review, Child Marriage and Childbearing Among Adolescent Girls Under Humanitarian Setting of LMIC.
Hi, my name is Shiyu Liu, but my friends like to call me Shirley. Today, my master's essay's topic is Scoping Review, Child Marriage and Childbearing Among Adolescent Girls Under Humanitarian Setting of Low Middle Income Country. With the respective time and purpose of this presentation, I will only be covering the child marriage. Up to 2022, there are 274 million people in need of humanitarian assistance. Unfortunately, regional conflicts and their aftermath for past decades continue to cause millions of people suffer from the humanitarian crisis and displacement. For example, we have Syrian civil war, Yemen conflict, stateless Rohingya, and Somali civil war. Among those, women, girls, and young people are often disproportionately affected with increased exposure to inequality, stigma, sexual violence, human trafficking, and forced marriage. And there are 55 million of them in need of sexual reproductive health and rights services. To better focus on the young adolescent girls, there will be 100 million young women become child brides by 2030, and there was 21 million adolescent pregnancy in low middle income country by 2019. My scoping review focused on the young adolescent girls' marriage and childbearing under humanitarian setting. In humanitarian setting, social structure is often disrupted through direct violence, trauma, and instability, and family formation is most susceptible. However, family formation is rarely mentioned nor discussed. It consists of two essential layers, marriage and childbearing. However, in terms of young girls under the humanitarian crisis, their family formation boils down to child marriage and adolescent pregnancy. By conducting this scoping review, my goal is to understand what are some unique drivers steering young girls into child marriage and early motherhood. What are their perceptions of marriage and getting pregnant and becoming a mother? And most importantly, is there any decision-making during the process? Lastly, can we identify gaps in the humanitarian research and aids when we're trying to study and help them post-war? The database I utilized are PubMed, Scopus, Embase. The keywords I used were refugee, that includes displaced people and also asylum seekers. For the family formation, I used the pregnancy in adolescence, child marriage, and early marriage. Even though not all people in humanitarian setting are refugee, the mesh word identified this population as refugee in PubMed database. Some important inclusion and exclusion criteria of the scoping review is that I mainly include all observational study that exclude the experimental ones, because cross-sectional study can help us understand the prevalence and also the trends of the child marriage and adolescent pregnancy before and after conflict. Qualitative and ethnographic studies are especially valued to investigate young girls' actual in-depth perceptions and experience. Here's the flowchart of the scoping review. I started with 336 literature, 73 papers were under full text review, and there are 33 left for the final reviews. The findings are grouped thematically. Themes under child marriage are grouped around the perception of marriage, culture norms, social expectations, safety, insecurity, and free, economic hardship and poverty, and eventually all the contextual and individual drivers must be integrated to discuss the decision-making. The theme under the childbearing include the perception of pregnancy and early motherhood, their decision-making, as well as childbearing within and outside wedlock. For the purpose of this presentation, I will only cover the child marriage part. So when we ask, why do young girls marry early post-war? Let's first look at what does marriage mean to them and how do they see it after the trauma and loss after the conflict? So the marriage is the restoration of the love and intimacy. Marriage can act like a normalizer and signify a desire of an ordinary family life that fulfills the social and affective needs of homemaking, which basically it is a symbolization of normal, stable future that they have their own loving family in it. Second, let's look at how their culture and society expect from young girls. After a closer look at the war zone area, child marriage is a common practice and widely accepted tradition, even pre-conflict. So the girl-child marriage is a common practice that deeply rooted in the cultural traditions and centered on beliefs relating to purity, physical maturity, domestic responsibility, and childbearing. So an obedient wife and nurturing mother is what they expected from the girls. So we all know how culture influences, that's subtly but enormously shifting our perspectives. So vice versa, girls achieving those expectations are rewarded. They're doing something expected, so they are happy. Thirdly, when the war strikes, people lost their assets and source of income. They migrated or are forced to displace to host community that is not necessarily welcoming. Supporting young girls become a burden. Marriage equals to a way to less this financial burden, and with the bride price, it can be a source of income. Most of the literature has identified poverty as the most significant and most cited driving force of girl-child marriage to relieve the burden and lower the cost. Lastly, aside from the economic hardship, another fundamental difficulty faced by family is their safety. So now marriage equals protection. Even within the camp, single girls are at elevated risk of being kidnapped, harassed, even raped. Imagine that under the culture framework stressing so much on girls' puberty, with family needing to protect multiple girls, marriage is transforming the responsibility to their husband. At the same time, by doing so, we will have the girls' reputation and honor saved. So we have to do it quick. And up to now, we have not even mentioned the mental health of the young girls. With all the safety concerns and fear of damage to their honor and reputations, their mobility are highly restricted. They drop out of the school, lost their friends, their peers, and they're in isolations while living in a crowded, even hostile household environment. Finally, let's talk about decision-making. Historically, from the outside of the world, child marriage is a violation of human rights, and it was perceived as undoubtedly forced. However, one question I do want to ask is that after considering all the factors above, do you think the girls themselves understand their own situation? They're not stupid. Yes, they do. So the majority of the literature has demonstrated the young girls understand their judgment will be always colored by the current situation, and there is active participation in decision-making. They want to change their living environment, even if it's small, but it's still their own private space. They want to make new friends, even if there will be their in-laws. They want to become someone that takes charge of their own life instead of being victims. So people will argue that with all the difficulties and oppressions, would you call this decision-making? I feel like they're just like all of us. We can only make decisions based on the information we can gather at the moment. So it is decision-making. So the decision to enter early marriage was described as assessment of numerous factors, including economic hardship, insecurity, and the loneliness caused by the conflict. And one Lebanese professional stakeholders says that, yes, child marriage is against girls' human rights, but the problem is that none of their other rights have been or will be guaranteed, even if they does not get married. For example, their education, their healthcare, their safety. So it's not because they're cruel or barbaric, they simply have no choice. And finally, the gaps I have identified are the empirical aids, especially the awareness session for reducing child marriage, have shown limited success. A united effort should be put into expanding more options for young girls instead of preventing one options they have in life. We need to reduce child marriage by addressing structural difficulties faced by young girls. For example, fundamental livelihood and safety issues. We can open access to the vocational opportunity, safe and culture comfortable school environment, and adolescent mental well-being. However, these interventions are still in advocacy stage and rarely operationalized nor studied. I know 10 minutes are very hard to include everything for this type of scoping review. So here's my summary slides with some takeaway points. That I have read hundreds of literature to find 33 of them to generate my findings, by adding more nuances to the narrative, knowing that study of child marriage is a complicated integration, and there is decisional making by the young girls, although it's a difficult situation made under a difficult decision made under difficult situation. And the gap and the main conclusion are the intervention suggestions. Programs should target structural difficulties in reducing child marriage. And that is all. Thank you guys for your time. And also special thanks to my amazing reader, Lania Zizerman, and also all the PopFam department, my family and my friends. Thanks.
Okay. Thank you, Shirley. Welcome. So any questions? Let's see. Oh, is it Youngie?
Yes, thank you so much for the presentation. I learned a lot from that. So while you're introducing the gap session, I'm wondering why the awareness session has limited success.
Oh, thank you for asking this questions. It is actually surprising to me because we come to the war zone or the host community, try to help them provide the humanitarian aids. And the most direct way that we provide to the people are recruiting all the mothers and the young girls to our awareness session to let them know, oh, child marriage is bad, it's this and that. However, what we're doing is we're directly challenging their culture and traditions. And they don't think so. And by doing that, we're making them think that they need to uphold their rights even more and their culture and traditions. So that's why the awareness session is not working and was very limited success. And now for the awareness session, we're trying to redirect it to the concrete negative consequences of the child marriage, or we'll include the young boys and the men in the awareness session, because we need to be culture aware to the population we're working with. So including the man who has decision-making powers, that will do the trick. And additionally is that we redirect our interventions to the structural difficulties. Thank you.
You guys did a great job, and particularly good job at answering the questions.